So first, I want to welcome everybody to this Lunch and Learn with Sherry and Nate. And I'm going to let them introduce themselves as they talk about mental health isolation and the pandemic from their point of view as practitioners in the field. Sherry and Nate, thanks for being here. And this will be, it's being recorded now, so it's going to be available on our website probably this afternoon after we've finished and we have everything done. So Sherry and Nate, I'm going to let you take it from here and welcome.
Nate, why don't you go first? Because what's cool is we both have a little bit of different perspectives. So I'll let Nate kind of start.
So my name is Nate Mochizuki. I am a therapist in the adult clinic at Gavia LifeCare Center, and we're located in Rochester, New York, particularly in Greece, and we're an outpatient clinic. So I was going to talk about first how I got to this role to be in mental health. I have a little bit of a different path than a lot of my colleagues. So I am an ordained Presbyterian minister. I have a Master of Divinity, and then have done 5 units of CPE, and have always been drawn to the, I guess, the one-on-one conversations with people that tends to come up in parish work, but I've also done a lot of chaplaincy work, have been on a hospice team. So it's wonderful to have hospice team members with us. And again, have always gravitated towards those conversations where I've gotten to get to know people and their stories. And in chaplaincy, we get to do that, whether at the bedside or other settings, and certainly got to do that in hospice when we got to know people for longer periods of time. There was an opportunity that came up as Gavia was getting started, as they were looking for somebody who could do spiritual counseling, and that can be defined in a myriad of ways depending on the person. And so I saw that come across my desk and contacted Sherry, and now get to do both spiritual counseling and I guess what we call more traditional counseling. And so it comes for me at the clients that I see. It's a variety of issues. It could be depression, anxiety, OCD, a whole host of other things, and a component, if that's relevant to them, could be issues of spirituality, or just trying to integrate that more into their lives. So that's my background and how I got to where I am.
Yeah, thanks. The reason I asked, actually, I was going to go first, but I'm sorry, Nate. The reason I asked Nate to go first is because I thought, Nate's got literally the hands-on role as a therapist in our agency. And my name's Sherry. Now I'm the executive director of Gavia LifeCare Center and started Gavia LifeCare Center in March of 2021. So we're almost, not quite 2 years old. I'm a licensed clinical social worker. I actually have a doctorate in counseling and education. And so when I started Gavia LifeCare Center, the goal was, again, so we're a mental health agency. So as a mental health, Office of Mental Health regulated agency, besides all the regulations that go with it, the benefits are that we get to really provide services across the spectrum. And we're able to hire people with a master's degree who maybe wouldn't be able to practice or because they wouldn't be licensed like in private practice. So that was kind of our goal when we opened Gavia. And so, we opened and we start getting calls and people were calling for spiritual counseling. And I'm looking at all my colleagues going, what the heck is spiritual counseling? So I was like, okay, well, let's hire an MDiv. Maybe they know what spiritual counseling is. So it was really cool when Nate applied. And again, it was interesting because, of course, we practice as social workers, and even my philosophy is kind of a biopsychosocial spiritual model, right? Well, then regulations are kind of like, well, you need to be a licensed social worker, a licensed mental health counselor. And I was like, well, hang on a minute. Nate brought a great set of skills for us, not only in the spiritual realm, but again, in his experience. So it took a little bit of some discussions with the Office of Mental Health to talk about, well, why would you hire a master's in divinity when nobody has done that? Which, again, I think is really unfortunate that no one had done that, because again, there's this traditional kind of approach, and I was like, no, I think we need to kind of be broad about this. So we've been very fortunate. We have 2 music therapists, 3 art therapists, mental health therapists, social workers. So it truly feels like it's a multidisciplinary team. So that's kind of, so that's how Gavia, that's how we started. That's who we are. We have an adolescent clinic, and we're working some now with developmental disabilities and mental health. But there's the whole role, I think. So again, it's been fun beginning to teach clinicians how to also think a little bit more, metaphorically out of the box, that it's not just about mental, that you can call up your art therapist friend down the hall and say, can you help me? Because this isn't working. Can we go at it at a different angle? And actually yesterday I was talking to someone who's doing a grief and loss group, and I was like, well, have you had Nate come in and do a thing? She's like, oh, that's a great idea. I'm like, yeah, have him join the group and do a little presentation and talk about the role of spirituality and grief and loss. So it's been really exciting, at times challenging, as we try to help shift the model a little bit. So, and my puppy's with me. He's a bit of a therapy dog. Sorry. You'll see his head bopping.
So we wanted to touch on the pandemic and how that's been affecting us as a practice and how we see it affecting our clients. And so I can talk from, I guess, an anecdotal point of view of what I'm seeing with my cases and my clients. One of the things that I think we've been noticing, maybe a trend, is if there were any existing mental health challenges that a person was experiencing, the pandemic could often just magnify those problems. So I'm thinking of particular clients if they had anxiety that tended to pop up in social situations. The pandemic made this much worse because they were isolated for a while, and then they had to re-enter public situations as things got back to whatever normal is, and they could be around people, or they had to be around people. That re-entry has been rough. It's for them. For some, it's been good when they're able to do that at a measured pace, to be able to be with people in person. But if that social anxiety was already a component, that was made much worse by the pandemic because of all of those disruptions in our life and social lives. On the other side, if a person would identify as an extrovert, and in addition had mental health challenges, depression, anxiety, other things like that, the pandemic also made it worse because then they were much more cut off from their social supports. And so some of them would tailspin into significant episodes of depression because those social supports were cut off. Their daily rhythm of seeing their friends, of activities, were shut down for a time. So that's definitely some of the impacts that I've been seeing in the pandemic. Is it's in the multitude of stressors that people already had, it was an additional thing that was a pretty significant change to their lives, which then complicated and added to whatever challenges they were already facing.
So from from kind of more the administrative community view, which is the view I have, a few things happened. So just to backtrack, when we opened Gavia in March of 21, the pandemic was we were still in the midst of the pandemic. And so we're thinking, okay, then we got a little space because everyone will want telehealth. Well, oh my goodness, we had within months, like 50%, over 50% of our sessions were, can we meet you in person? Can we meet you in person? Because by then it had been over a year. People were done with Zoom. They like, I want to see you in person. So we had to pivot very quickly to being able to provide in-person sessions because nobody was doing that. And we're like, well, yeah, again, we can do that safely. By then, again, we knew a whole lot more by then. And so we were able to do all the things that people were doing back in the, around in 21. So that was one impact, is that people wanted to be in person because they were, again, the isolation that Nate speaks about. It was exhausting people at that point. The other thing that was kind of going on is kind of, we also saw some pros and cons of what the pandemic. So again, administratively and systemically, suddenly when I opened, there was this, 10-page process to offer telehealth because, no one had been doing that. Literally within weeks, they were like, well, you know that, guess what? We've eliminated that whole thing. It's a 1-page thing. You do this, you're doing telehealth. Like, oh, I'm sure my colleagues were not. It's like, so that like regulations that previously they thought would never, that were going to be these big, long, very arduous and difficult regulations, literally with the swipe of a pen, were gone. And now it was like, do these 3 things and you can do telehealth. So it cut and eliminated all these barriers that we've been fighting for, but that nobody thought could be done. So, so that was, as far as regulations and the bigger point, COVID forced people in their pivoting to change their view and be able to say, why do we have this reg? Do we really need it? Can we find other ways around it? We're like, oh yeah, we can. Like, well, then let's eliminate it. Let's move it. So that was really, again, kind of a positive outcome, if I can say that about the pandemic. I think the other piece is, again, even the whole, the prescribing and meeting with psych NPs and the part about providing services to rural America, suddenly that became, again, available where it was so difficult prior to that. Again, they wiped out a whole, you can see anybody in New York State, you're like again, the caution and the fear around, well, are we doing it right? And scope of practice, and that they were finally able to say, well, why not? Like, whether they're living in Geneva and Rochester or down in Steuben County, like you're in New York State, you can meet with them. Like that's part of that's your license. So that part worked really well. They allowed phone therapy, again, realizing not everybody has internet. So allowing phone therapy, which again, they thought that couldn't be done. And we're like, no, not that that's ideal by any means. It's way better than nothing. And for people, again, who are isolated, who are struggling, who are like, I just need to talk to someone. We were doing phone therapy. So those are some of the other sides of what happened with this pandemic. Nate's very correct as far as it magnifying the struggles. The people who were struggling just struggled more. So
how do you want to do questions? Can we ask questions as we go along? Mm-hmm. Is that all right?
Yeah.
Okay. I'm thinking about, I know in our own organization that accredits our program, everybody went to online classes pretty much because they had to. And our students had to do a lot of times spiritual visits by phone or spiritual visits on an iPad, using new technology that they weren't necessarily as familiar with, but suddenly they became familiar with it in a much quicker way than they normally would have. But I'm wondering, what have you given something up? Like what I found with my classes is students don't want to go back to in-person, even though I believe as an educator, in-person is way better. You can do it virtually, but in-person is better. It's just better. So I'm wondering, how has all this going to phone, going to video, how has it impacted the quality or the quality aspect of care? I guess that's where I am.
I mean, I can answer that. So you are 100% right. And it becomes, for us, it becomes kind of, quote, a therapeutic issue. So, when someone is like, well, I'm not really, I'm kind of tired. Can I just do Zoom? I'm like, hang on here a minute. Today, we need to look, what's going on that you're kind of, are you avoiding? Is this kind of, are you using this to not have to deal with real issues? So we have had to kind of walk a line between saying to someone, you can come in, and I think it's really important you come in person, because I would really like to kind of that whole lay eyes on you, and so we've absolutely had to kind of at times push people a little bit to not use that as a way to avoid or to escape or to not address an issue. At the same time, you know, so yes, I agree with you 100%. In our initial sessions, we tell people normally we won't do initial sessions over video. I'm like, the first time I meet with you, I need to see you in person. It's really hard to do a full assessment of someone when I'm not seeing them and feeling them and hearing, like, you know, in front of me. So yeah, we've had to challenge a little bit.
And I would echo that as well. I think like Sherry was saying about the positive things about this and being able to use technologies that people can connect with us from a variety of geographic locations. You know, for some people who live in a certain area and they don't necessarily want their mental health care to be coming from someplace within their community because it's a small community, so they can connect with us through video, and that we're able to provide that resource to them. And so that can be a really important thing. And so sometimes, even if we only have those to be able to connect by technology, you know, it's better than nothing. And for some people, if distance is an issue, or if they've been on the waiting list for a long time, if we can make contact and maintain that contact, is really important for that. And also to Sherry's point, but there is times when it's like, okay, we really do need to see you. If there's a lot of issues going on, they're not stable, there's a lot of risk factors, then we will insist we really do need to see you. And because the flip side of that convenience is then they may not take it as seriously. They're being committed to their treatment. And so we do have to find that balance and sort of evaluate that in a case-by-case basis of what is going to be most helpful for this person in not only today, but in the long
run. Amanda and Caitlin, since you're here, do you have specific questions that you have to ask or thoughts about what we've talked about?
I don't think specifically a question, but more so, I'm going to go with a praise. I'm originally from Rochester. I left right when COVID was hitting. So obviously that was before your agency existed. So I'm happy that there's another agency in the area that it's so comprehensive with what you offer. I think that's great. And it's definitely something that, you know, we could use down here as well, but I'm happy that it's another resource for the Rochester area. So that hits home a little bit. So I'm very appreciative of that.
Thank you.
Oh, I was just going to say, I don't have any questions right away, but I'll definitely let you know if I do.
Sherry, I wonder if we should talk about just like the continuum of mental health care.
Mental health care, that's a great idea. Yep.
And how we fit into that.
Yeah. Okay, so do you want me to start that?
Sure.
Okay, so again, just to kind of give you the context. Okay, so New York State, the struggle we have in New York State is that there are significant silos between agencies. So the Office of Substance Abuse and Addictions, the Office of Mental Health, the Department of Health, Office of Persons with Developmental Disabilities, they are all probably within 2 floors of each other, someplace in Albany, but you'd think that they were miles apart from each other. They all have their own regulating body, their own set of regulations, their own set of everything. So I give you that context because the continuum of care then is also then influenced by that, which is unfortunate. In the substance abuse world, where I come from actually originally, there is a very comprehensive continuum of care. They do, you know, there's inpatient is really inpatient treatment, and there's outpatient and outpatient treatment, and then there's aftercare, and then there's individual, and they have got it mapped out. The mental health world does not have it mapped out so well, unfortunately. We're trying, but it's not quite as well mapped out. So for mental health, one of the biggest misnomers is that if you go inpatient for mental health treatment, you're going to get treatment. And that is actually not very accurate. Traditionally, there's one in all of New York State, an inpatient mental health agency that is a voluntary admission. And that's outside of Albany, outside of Saratoga, actually. Otherwise, inpatient hospitalization in New York State is usually, you are quote committed or sent there because you've threatened to harm yourself or harm someone else. Like that's how you get inpatient. Like people, I'll have clients like, don't go sending me to the hospital. It's like, trust me, you have to do a lot more to get sent to the hospital. Like that's not bad enough. and I don't mean to be cavalier about it, but like literally, you have to have those two criteria, one of those two criteria. And then when you are admitted to an inpatient hospitalization for mental health, it's about stabilization. It's let's get you stable, let's give you meds, let's get you back off the crisis. And it's like 2 days, 3 days, 4 days, and that's it. You are out. So it's not quote treatment necessarily. It's stabilization. Again, there's absolutely a need. There's a place for that. It's critical for absolutely. If somebody is feeling intensely suicidal and unable to control those ideations, then yeah, we want them to go someplace safe where they can't hurt themselves, and they want to go there. So it's good for that. The next kind of step down from inpatient would be something called partial hospital program. Again, unfortunately, partial hospital is still a lot of remote. That was a very painful pivot for them with COVID. Because that was an in-person, mostly all day. So call it 9 o'clock till 3 o'clock, 5 days a week, lots of groups, lots of individual med management. Like it's a comprehensive program. It lasted for maybe 3 weeks. So it would be this intensive 3 weeks every day. So again, quote, partial hospital. You're not admitted, but it's intense. When they went to remote, it was very difficult for them and for the clients because, to your point, Marianne, that ability to be in person all day with people and have that interaction was exactly what they needed to get better. And now here they are trying to do it remote. So that was hard. So partial hospital is again 2 to 3 weeks, and then from there it's kind of outpatient treatment. There's a couple variations of outpatient treatment. Again, the traditional is what we have, an outpatient mental health agency, and it's medication management and therapy. And that can be, 1 day a week, maybe 2 days a week, not often because the demand is so high. Groups, we offer groups, most offer group therapy. There is something called PROS, which is, oh, sugar. What is the acronym for PROS?
So like personalized recovery-oriented services or something.
Nice work. You got a point. That worked great, Nate. Yeah. So that's so PROS is again kind of an all-day program. It's voluntary and it's totally voluntary, and people can stay in PROS for years. And it's basically a lot of life skill training and group. It's all group work, almost all groups. There's like 20 groups a week, 25 groups a week. They come and go. And generally it's individuals with kind of a more serious degree of impairment. So who are on disability, not able to work. Their mental illness is to such a degree that it's just really impairing them. And they're like, so they need some place to kind of be during the days that helps them just, again, learning life skills, learning how to, be assertive and navigate shopping and navigate. So PROS is great, but again, it's a pretty small sliver, to be honest, of our population. We right now have over 1,400 clients at Gavia. And we refer to PROS, we've referred 3 people to PROS. Like that's, so the degree of people, so that just gives you a sense of those coming for counseling, how appropriate they would be for PROS. It's, because again, the people recalling us are, not that they're not all working, but if they're not working, they're again at home taking care of families, or they're at home trying to manage their mental illness on an outpatient basis and during the day, but they're functioning all well enough that they're all, they're living and doing well. They just need to get additional help with whatever it's the anxiety, depression, whatever's happening. So that's kind of the continuum of care. That's what we have in New York State. So.
And so I think that makes it can be difficult when we feel like we're sort of maxing out what sort of effort and services we can offer to people, but they're not qualifying for these higher level of cares. There's not a whole lot of gradual steps up that we can readily refer them to. So yeah, kind of compared to the substance abuse world, where there's more sort of gradual steps that people refer to, it does make that a challenge.
So is the substance abuse system, that healthcare system, is that separate from mental health?
Oh, yeah.
So they're two very different systems?
Uh-huh. Different set of regs, different set of criteria, different regulating bodies, different credentialing bodies. So you have an OMH license, you have an OASIS license. So last year they created, quote, an integrated license, which, I'm sorry, I don't mean to laugh, was the most complicated set of regs I've ever read in my life. Like, in only the fashion New York State can do. So it was like, 300, I'm like, I don't know how many pages, but, and it was because they're trying, it's the worst of a blended family. Like, so because neither of them wants to give up their regs, and so the OMH world is like, well, but you have to hire only people with this credential. And the substance abuse world is going, well, no, we don't. We hire people with a KSAC. And the OMH's world is saying, well, we don't recognize that credential. So that's the kind of stuff, in full transparency, that the struggles are. OMH world, it's a master's degree, done. The substance abuse world, well, again, a KSAC is a certificate program. You don't even have to have a bachelor's degree to get one. And so again, so you can imagine kind of what happens when those two worlds start talking to each other, and they try to combine. So it's very hard to blend those two worlds. And even the training for people, again, and you two can speak to me about social work, but if you become a therapist and you go into the substance abuse world, and then you're not allowed to do mental health counseling, because most of them, their scope of practices, you're doing substance abuse counseling. So even if they can kind of do some mental health counseling, then it's what we refer out for mental health counseling. And in the mental health world, well, no, I have counselors I have many counselors here who have never worked with an individual who has substance abuse disorder. So they're like, well, what do I do with that? Like, I don't even know it. So they refer out. So again, I think it also, unfortunately, goes back to some of our education, that we don't always, I think, help integrate the training either, which makes it also difficult.
It seems like a no-brainer to me. Maybe I'm a little judgmental here, but it seems like a no-brainer that those two things are so closely related and overlap in so many ways, that there should be a way that we can use the services and the skills to the best benefit of people.
Yeah, because people are not bifurcated. We don't have an arm that's in the substance abuse world and an arm in the mental health. I bet you, I don't know, well over 100 clients that are in two agencies. They're doing their substance abuse world over there. They're doing their mental health counseling with us. We often will see people with dual diagnosis here, but again, we also don't have the capacity. If someone is actively drinking and actively using, that interferes in their mental health work. So then we have to say, so we don't have the structure to do, like, offer a 3-day-a-week outpatient program here. So then I don't have any options but to send them over there. So again, it's a hard systems issue. It's a very hard systems problem.
Can you be certified for both? But you have to, when you bill, I bet you have to bill for one or the other.
Well, it depends. Yeah. And again, being certified for both means I have to follow 2 sets of regulations.
Oh, okay.
Which I've not chosen to. Right. No, sorry, I'm not doing that.
I get it. I totally get it.
Yeah. My therapist would absolutely have, again, my goal is to make paperwork as easy as possible. If I had to add another whole layer of paperwork onto this, I would lose, they would all just be gone. I would have nobody working here.
Yeah.
So. You're smiling, Amanda.
I can only imagine, I think what a lot of people say, you can't pour into someone else's cup if yours is empty, and it's the same thing, it makes you, I've heard a lot, it makes you a better therapist or a better counselor if you've got your own therapist. So I like that you linked that in there.
We had some other questions. Nate, do you think we should kind of address some of the other ones?
Yeah. So there were some questions that were sent ahead of time to us. And the first was about people taking the CBD/THC gummies instead of medications, saying that that seems better because it's natural. And so some people are opting to do that as opposed to taking medications. And so somebody was asking, what do we think of this particular trend?
So that's a really great hot topic. And well, Nate and I were talking about this before, and you had a great answer to that. It was actually, I thought, better than mine. What was your answer?
I guess the thoughts that came to my mind is just because something is natural doesn't mean it's necessarily good for us. There are a lot of substances in the natural world which are not necessarily good for us. But also, I think we find with our clients who are on medications or using these substances or marijuana in other forms, they all react differently. So a medication for one person can work great. For the next person, it has adverse side effects. It does the complete opposite and makes the symptom worse. And then so we have to shift from there to say, okay, what can we do differently? Is it a dosage issue? Is it a timing issue? Does it need to be combined with this, or is it interacting with this? And so for each individual thing, different things will work better. So certainly if it works, the gummies are working and it is taking the edge off the anxiety. Okay. But we do encounter for some people that those substances can actually make the anxiety worse. So they may feel a little bit better for a time, but then afterwards, as the effects continue with them, they are feeling paranoid. And so that's sort of an added layer to what they were already dealing with. And so I guess I would say I don't think it's going to be a universal fix for everybody, because everybody reacts differently and they need different things, and they react to treatments differently than the next person.
And I think I would take a bit of a more systemic approach to this question. And I have this discussion all the time with people that we want people want a medical approach. The medical model is you take an x-ray, you find the broken leg, you cast it, and you're done good. And they want the same approach with mental health. And mental illness is not black and white. It is not all or nothing. It is very gray. And we're all generally really uncomfortable with that. We don't like, well, it depends. They don't like that answer. We want, well, will it work? Will it won't work? And unfortunately, in mental health, it is often, we're not sure. Like Nate said, the exact same medication, someone takes it, it's awesome, and they're like, I'm good to go. And the next person's like, oh my golly, what made me worse? So we know a lot, but we also don't know a lot. Our brains are pretty complex. So there is just not always a definite yes or no answer to that question. Again, my 75-year-old aunt who has a little glass of wine every single night that helps her go to bed. Well, you have at it, because it helps her sleep. She's great. She's sitting at home. Who am I to tell her not to have a glass of wine every night? My 22-year-old niece, on the other hand, who's having a bottle of wine every night. Well, I'm kind of concerned about. So, again, it's not, again, it's biopsychosocial, spiritual. It's a whole picture. And that sometimes is the hardest part, to help people understand that it's not just one piece that helps create the answer to the question.
And I think too, I try to encourage my clients when they are broaching the subject of medications, that this is an ongoing conversation that you're having with your provider. They do need to trial things. They're going to start with a low dose. They want to see how you respond to it, and then from there they're going to make adjustments. And so, encouraging people to give medications, if it's indicated, a chance to work. Because some people say, well, I tried it for a week and I didn't like how I felt. And it's like, well, it's going to take a lot longer for that to be working. And also too, I think when people get medications from their PCPs, those doctors have a limited scope of what they're comfortable prescribing because they're generalists. They've got to cover a myriad of different issues, and so they're only comfortable prescribing a certain type of drug or a certain class, and in this very limited amount. And so I encourage my clients, if you want to have a discussion about broader options, let's talk to our psychiatric nurse practitioners, because they do have more options available, and we can have conversations of, okay, this didn't work for you. You had these effects, but there are these other different classes of drugs or different type of drug in that same class that could be an option. And so just because we hear, oh, I was on this drug, it made me feel terrible, that again, doesn't mean that's going to be the same effect for you. And there are other options, and this is an ongoing conversation that you can have with your providers. So again, I just encourage you to, have a conversation. You don't have to take it, but at least that there are options available for you.
The next question we had was, and actually this is probably, I think Amanda and Caitlin could probably answer this better than us, was about survivor grief and about, again, during COVID especially, but even still, there's times when, I didn't have a chance to say goodbye to the person who I lost. I didn't have a person, we didn't have any of the rituals. We didn't have a chance to kind of, go through all of, what the process we might have gone through, and how do I now, manage that? How do I cope with that? And again,
Well, my first thought is to still do those things. Write someone a letter, say to them what you'd like to say, have a little celebration, a memorial in a way that's meaningful for you to honor that person.
And I've talked with some of my patients about, well, kind of like what Caitlin said, what do you want to say? You can still say it to them. I know everyone has a different belief, but if you feel like they're still here with you and they can hear you, say it out loud. If you feel more comfortable writing it down. If you regret you guys never took that trip to Tampa together, we'll go do it in their honor. Definitely, things like that, to talk about different ways that meet their level, what they're comfortable with, and still engaging in that closure, but also a celebration of the person's life and their memory.
I'm so glad you just said that. So I actually still have, I still see clients. Everybody, every director, every supervisor still carries a case out. That's just kind of our philosophy. I do that for a couple of reasons. One, if I'm in that electronic medical record, then anything I'm asking them to do, I have to do. And then when something doesn't work, I'm like, has this not worked for all of you? So it helps me kind of, keep a finger on what's happening. It's also part of my day that I still love, because I'm a therapist still at heart. So at any rate, I've had it was just one of these weeks, I had 2 clients both come to me who had lost their spouses with completely unexpected and no warning. And both had found them. So really, really difficult sessions, like, and the last one in the last week, one in the last 2 weeks. So just, came in and just grief. And it's so hard to, like, I know you guys do this all day long, to just sit with someone, right? To just sit with them in their grief, which is what we do. But it's really hard, because we can't fix it.
Yeah. That's what my first thought was. Yeah, just be there to hold space for them, because, oftentimes I think other people put a timeline on grief, or, their own sort of restrictions on grief, and it's such an personalized experience. So yeah, to just have someone to be there to listen and process what they went through, I think is so meaningful.
I think too, you can remember that we can have a continued relationship with people even after they're gone. It doesn't matter if they believe in a higher power or the divine or the sacred. There's still possibilities of having conversations with them within yourself, or setting something up within your home or in your yard, a garden, or something where you can go and have a sense of their presence with you. So that's often down the road, not in that moment, but down the road as they're processing their grief, deciding what kind of relationship they want to continue to have with this person. And maybe they say, nope, they're dead and I'm done. Okay. But a lot of people continue to talk to people who have gone before them and feel that they're heard.
Yeah, that's a really great point. And I think it dovetails with what Amanda said. So, if they wanted this trip, then yeah, to go on it, you're right, is both honoring. Yeah, so it's a very, very awesome point. I like that a lot.
I was talking with a colleague who ran a grief and loss group, and she was saying for the pandemic that there was, as we were saying before, there were some positive and negatives to it and how it affected people's grief process. And so certainly if someone lost a loved one in the hospital and it was at the height of visiting restrictions and I couldn't see them, that certainly was a huge impact to how they were experiencing their grief and not having the closure that they might have expected they would get to have. But for some people, they found the pandemic was helpful because we were all sort of quarantined from each other, working from home. They had space to themselves. And so working from home and maybe not seeing people as much, they had that quiet time to themselves. And so they were able to, and that for them, that particular person, that was helpful in their grieving process. So it was like, for some people helpful, for some people it was very traumatic. And I think, like as we've been talking about today, there's no sort of one path through grief. Everybody's path is different. And so the pandemic just threw multiple factors, X variables into there that maybe just complicated it more. But certainly when talking with people in their grief journey, it's like, okay, this person's grief is totally different from this person. And what is helpful for them, so when we talk about rituals and how to be creative with that, someone is able to find these ways that helps them through it. And then I could sit with somebody else and then we're coming up with different ways that is able to help them through it. So even with the extra layers of the pandemic, if the approach is each person's grief is unique and like has been said, we're holding space for that, we can still work on that and help them through that process.
Great point.
As people were talking, I was thinking about in the medical world, caring for the caregivers, like the deaths that were difficult for the healthcare workers. And in hospice, I know several times hospice has been shut down on being able to make in-person visits. My own students who have been in hospice settings and been told, they're with people who are near the end of life and they're not allowed to go visit them in person anymore. It's almost like a moral injury.
Yeah.
And I wondered, have you had any experience with healthcare workers who have come because of that, who have experienced just complicated grief or extended grief, chronic grief, moral injury?
Passion fatigue.
Yeah.
Yeah. Yeah.
Because that wasn't necessarily as much a part of their job as it became during COVID.
I haven't. We've had some here at the agency. So I've had staff who've talked about that with some of their clients who are in the healthcare field or in the professional who are caregivers, medical professionals, and just the word complicated doesn't even seem to do the word justice. Like super complicated. Like, I don't know what's more. I want a bigger word to represent just how full and how big that is for them.
Yeah, and it sort of makes me think of when people think about therapy, it can be generational or culturally, there's some stigma attached to it, and so they don't feel like they should reach out for help, or they don't want to because then they will feel a certain way or they'll feel judged, and so certainly as we read the notes of people who are seeking therapy, our hearts are like, we're glad you reached out. And so certainly for caregivers, and so for clients I work with who are in caregiving capacities, professional clinicians, for me, it's just, I'm really glad you've reached out, because that caring for yourself, even if you don't rise to the level of serious mental illness, I'm glad you're here seeking help, creating space for your health, self-care, and so for those sorts of things. So certainly for anybody listening who is in those caregiver roles, as therapists, we want to be able to help care for people who are caregiving. So we have people, therapists who are seeking therapy just for their own well-being, and we think that is very important. So certainly I would encourage people who are in any sort of caregiving role capacity that therapy can be a wonderful place for you to recharge and to find healing, to work through things that are bringing you down. Again, it doesn't have to be, I'm having serious mental health issues that are debilitating my life and I need to go to the hospital. It can be a whole range of things. And so if that is moral injury, if that is compassion fatigue, I think that is absolutely what to talk about.
So thanks a lot, Nate. I'm so glad you said that. So yes, everything you just said. But yeah, it doesn't need, again, it doesn't need to get to the point where you're needing an ice, you're so debilitated you barely can work. Like it's much better to come when you're like, all right, I'm just really have had more than just a bad day. It's been a bad month. I need to talk to someone. Like that's enough. It doesn't need to be any more than that. It just is enough to say, because keeping it in our own heads is generally not a good place for it to stay.
I wonder too, well, there's that culture in the medical world of just suck it up, keep going, go on to the next person. To remind people that if you go see a therapist, it's not a life sentence. It's like I go for a month, or I go every week for 4 weeks, and then I get through it. Like we get through things and we're back in the sandbox of good mental health.
Right.
It's not like you're signing up for therapy for the rest of your life, like some of us. So it's a tool. It's a tool in the box.
Well, and that's part of this. It's the good and bad news that I've been living in Rochester for 30-something years. I mean, I'll get a call from a client who I saw 10 years ago, because I haven't changed my cell phone number, who just, again, lost somebody or new crisis. Do you remember me? And I try really hard to say yes. And in full transparency to all of you, we don't always, but I try. And comes in and it's 3 or 4 sessions. And I'm like, okay, I'm good. And they leave. So sometimes that's what it's about. It's, so I'm so glad you said that, Marianne. It's not always forever. It's sometimes I just need help, and good. Now you know who I am. I may call you in 6 months. So I said, absolutely, call back. Like, yeah, it's sometimes how it works.
Yeah. And we just had this didactic in our CPE group with about mental health in general. And I like to think of mental health as like a sandbox, and we're all playing around in that sandbox. And usually things are we have little fluctuations, but we're managing. But sometimes something happens and it throws us out of the box.
Right.
And we either don't have the tool, or we don't recognize that we have the tool. We've forgotten about it. We don't know how to use it anymore. And we just need somebody to help us jump back in the box so that we can be playing in our normal range. But that's true for anybody and everybody. Absolutely. So it's so important. I'm so glad that you're there.
And just your metaphor, to take it one step further, and sometimes we forget that somebody in the sandbox can help us, but we forgot, like you said, I'm like, remember? They're like, oh yeah, I just need to do that and that. And they're like, thank you. But that's because, again, like you said, you get thrown out, you get dysregulated. Like, it's really hard when we're in the middle of an emotional dysregulation to think rationally. And that's sometimes all it takes is, you've got 3 people, they'll help you. It's like, oh yeah. They'll bring you right back in the sandbox and you're safe. So great metaphor.
I'm noticing our time, and I know there were questions about adolescents and Medicaid, Medicare accessibility issues. So maybe jumping to the adolescent piece, there was a question that we were discussing earlier. People are wondering if there's a trend of trying to medicate kids too quickly. So I work on the adult side. I do work with young adults, so they could be in their early 20s. And so I guess just sort of some of the things that I'm seeing currently is, it's again, just echoing back to that comment about the pandemic of, if there were existing things before that were challenging to this young person, the pandemic tended to magnify them. So I'm thinking about like social support networks. So if a person was isolated before and was having trouble engaging with their peers or making friends because of something that was going on with them, say they were going through a traumatic experience, the pandemic has made it much more difficult to break out of that isolation that was already forming. So that's one thing that I'm saying, and so helping people to find ways out of that isolation and to connect with other people has become very, very important. And so group therapy is a wonderful place to make a gradual step in that direction. So I say that's sort of one thing I'm seeing with young people these days. Another piece that we had talked about sort of generally impacting adolescence is we think there's a generational shift in how people are talking and thinking about mental health. So again, for certain generations or for certain cultures, there is an extra stigma attached to mental health, but it does seem like mental health is becoming more a part of the main discourse in society. But we did have kind of some worries about how it can be talked about in social media, because there can be a lot of, so it's good that we talk about self-care, we talk about not having stigma with mental health challenges, but we do sometimes worry for our clients that social media, while that it can provide that sense of validation, there is the elements there of comparison to people that can increase anxiety, increase depression, or there's that sense of feeling isolated, even more isolated than they already are, because they see people with this idealized lifestyle, and that can trigger those depressive or anxious thoughts. And so I think there are unique challenges for people these days growing up in today's society with the pandemic and those sorts of things. So that's sort of generally kind of what we're talking about for adolescents. So I don't know if it's necessarily this massive explosion of mental health issues for young people. It could be that they now have language to talk about it, whereas before it wasn't talked about. So that could be a piece, but this could be probably a longer term discussion as researchers look back at data from this time and are looking at long-term trends that may be much more clearer and interpretations of what's been going on. That's what we're seeing, at least in our current practice.
And just for a minute, put my researcher hat, my doctor hat on. We often love to make assumptions based on a sample of 4. All 4 of my friends, and so yeah, probably there's 40,000 people. So if I can help you put that in perspective. So I think that whole piece about, again, that it takes time to, like you just said, Nate, to recognize trends, to recognize what's happening. So while absolutely people are prescribing medications, I don't know if we can actually say, well, is this more common or not common? Because we're asking common for what? For this age, for this time, for this population, for this, like, it's hard if we don't have context around some of those questions, because the answer is it depends. The other quick question, just so the question about Medicaid, Medicare, Medicaid and Medicare absolutely cover mental health counseling. It's never a question about whether the insurance covers the counseling. The question is whether the agency accepts or the provider accepts the insurance. So unfortunately, it's the other question. We accept Medicaid and Medicare, but not everybody does, because the reimbursement rates are sometimes really poor. So it all depends on, and again, it's not even that, it's the paperwork. There are numerous, like, I can't even tell you the hours and hours we have submitting claims to insurance companies, and insurance companies that decide they didn't like something or suddenly decided to not pay us for this visit. Oh yeah, I guess that was a glitch. Never mind, we'll pay you now. I'm like, so that's kind of the issue. So that why people don't accept some insurances, and why it's our insurance company system is not necessarily an easy system to work in, but it is all covered.
And then there's certainly always the challenges of, you know, how they cover it. Do you have a copay? Do you have co-insurance? What's your deductible? And helping clients navigate that. That's it. It seems like, speaking from what we hear, but it does seem like that is always an ongoing conversation with people.
Did we get through all your questions?
Oh, the very last was just about race and ethnicity, and you know, again, I think that could probably be another whole long discussion. So I'm not sure. I kind of want to tackle it, to be 1,000% honest.
Well, we're about at the end of our time. Thank you so much, Nate and Sherry and Amanda and Caitlin, for being here. We will have another Lunch and Learn in March, and this is actually two parents who had a young adult child who died by suicide. And they're coming and they're going to be talking about their experience as parents and what that was like for them. And Judy and John are wonderful people, and I'm sure it'll be interesting and interesting to hear their story, and for them to have the opportunity to share it with other people. There is a short survey that should pop up at the end when you log off. It takes about a minute to finish. If you could do that for us, we would appreciate it. And again, thanks, Sherry and Nate. Thanks for being here.
Well, thank you so much for inviting us, and thank you, Caitlin and Amanda, for coming.
Yeah. Thank you guys.
Thank you.
All right.
Informative.
Have a great day, everybody. Stay healthy.
Bye.
Bye-bye.
Bye.